a report that came out in Lancet Psychiatry talking about a multidisciplinary research approach to what might be needed in the pandemic. And to do this, we work with the Academy of Medical Sciences in the UK and research charity MQ, Transforming Mental Health Through Research. And the process for this thinking really was to try and bring experts together from different aspects of mental health, so medical, psychological, social, with people with lived experience of mental health from the beginning, included in the, as it were, thinking and as co-authors. In addition, we commissioned 2 surveys early on, which amounted up to about 3,000 people as the first lockdown started in the UK, to try and think really both about getting perspective, and maybe this is a theme that runs through this, both about mental health difficulties and also the other side of that coin, which I still think is very much neglected, which is protective factors and strategies that are within our control under difficult situations, so both well-being as well as difficulties. And if you're interested in reading it in detail, it's freely downloadable in the Lancet COVID resource papers. I want to give you some high-level stuff from that and then go through a couple of details, but I want to end up really with questions about how does actually affect research now, and how can we try and think wisely about ethical issues as we go forward. So the bottom line for mental health is that it's as if mental health is a big concern, and it's a big concern that was already underserved and undertreated, a Cinderella, as it were, to physical health in almost all countries in the world. And what the pandemic is doing is exacerbating mental health inequalities across societies and globally. And we think about inequalities and vulnerable groups. What we way back when, last April, was there are certain groups that we need to really keep an eye on. So, for example, people to support people with existing mental health difficulties, children. You only know how that's been affected with, for example, school and lockdown. Older people. I speak from Sweden, where that's been a scandal of our time. Minority groups of many different types. There are also newly vulnerable groups that need attention, mental health research and support. And actually, some of this has already come up in this meeting. So but both the patients who are on the receiving end of care in ICU, we know there are high rates of post-traumatic stress and difficulties and delusions in patients who've been through a treatment, but also for frontline healthcare staff who are being exposed to trauma regularly, repeatedly in a line of work with increasingly difficult work patterns. And that was mentioned by John in his opening address as well. So we've got previously vulnerable groups and newly vulnerable groups. And mental health's a kind of complicated area. We need to keep reminding ourselves it's something that is very tractable and treatable and within our remit to do something about. And yes, most people, even pre-pandemic, do not receive adequate care and support. Certainly in the pandemic, there's a necessary focus on physical health, while mental health has been neglected. At an individual level, this may be in the necessary changes needed for remote delivery of patient care. But in particular, given the great rising demands that are coming in terms of anxiety, depression, particular vulnerable groups that need our support, there's a scalability level which we're rapidly running behind. And even when the pandemic's over, mental health is not going to disappear. Once you've established a certain disorder, you're looking at a potentially long-term trajectory. So we're standing now looking towards a 10-year future where this is going to be increasingly important. At a social level, there are all sorts of mental health aspects that are important around the public health messaging and the steadying of what we do, how that contributes to public level anxiety, how it affects decision maker, how our policy makers themselves are sitting and making decisions, how health messaging is managed. Some messages are designed for very acute and temporary crisis and deliberately designed to increase fear. Is that what we should be doing now? How are we assessing that intersection? We also know that some of the media reporting in and of itself, and there's one of our co-authors has been documenting this, particularly in the US, in and of itself is associated with difficulties and worsening symptoms. So it's as if we're slightly naive as a society to the impact of repeated media exposure of very negative events for which one has little control. So there's much work that needs to be scoped in terms of prevention, foresight, and seeing this as in a problem which has just started and it's going to be enduring and long unless we all start to act collaboratively now. And I don't mean just from April to now, I mean in the decade ahead. And to repeat the kind of well-worn phrase, there is really no health without mental health from in a long-term perspective, either for an individual patient or for society as a whole. If we go down to the details of the paper, and you won't be able to read all the words on the screen, we've talked about the different ways vulnerable groups are affected, and the first thing that happened was a flurry of letters, which was so helpful, which keep accruing about different groups are vulnerable in different ways and the specific needs they have. That's to be welcomed. And taking a biopsychosocial approach, just as one of our student speakers did earlier, we try to divide priorities, which I think remain today on psychological aspects that need addressing, from monitoring and treatment for the increases in anxiety, depression, self-harm, and potential suicide, which we're seeing. As well as I talked about the flip side, mental health research also needs to involve what's working well, not just what's going badly. So what do optimal structures work? What can we find that that might help and protect people?
Emily,
you may not know that your slides
are not moving. You're not on slideshow, and we're not seeing your slides.
Oh, when did you stop seeing them?
We have never. We've
only seen the front slide.
The front slide. You're not on screen show.
Oh, I thought I set that up at the beginning. I'm so sorry. Okay. That's really great you said that. Okay.
We
well,
all
in
told
that
you
case,
that your front slide is there, but we haven't told you till now that the others aren't.
Oh, but that's really weird, because in this variant of Zoom, I can see me, but not I can see my slide. Let me take you off slide share and bring it back, and I'll certainly share my slides. Are you able to follow what I'm saying orally? I feel very sad to can't see my slides. Okay. I'm just wondering, in respect to the other speakers, whether it's worth me faffing with the Zoom, which is looking intractable. Is that, can you see that now? Is this moving?
Yes, that's slide 2, 3, 4.
Yeah. This is what you just missed. Well, this is like one of these psychology experiments where you see if you paid attention, this will look familiar. And if you've dozed off, it'll all be rather new. But I'll try and catch up with myself.
You did it on purpose, didn't you?
I did do it on purpose. It was
You're still not on slideshow though. You're right. We've got your main slide, but all the others. You're still not on slideshow.
Can you actually see the main slide? Can you see it enough to read it?
Yes.
Yes. Okay. I think there's a Zoom bug, so I'll just leave it like that. Okay. So we've talked about psychological stuff. We've talked about psychological research priorities. What's going wrong? What's going well? What needs to be. Remember, mental health is a social issue as well, which is why I've talked about more sort of broader level stuff, from the impact of social isolation, of policies, of chopping and changing of policies, of how to promote behavioural adherence, how to send out messages that are fit for public health consumption. We've got the neuroscience aspect. And through all of that, and relevant to ethics conference, as well as what we were trying to flag up, is the importance of still adhering to the best practice research that one can. So I'm going to just, you've already heard me say this, I think actually we need to communicate more effectively, because what's in a way so incredibly stunning and disappointing is how little, as a UK as example, almost no research has been funded on treatment innovation for mental health during the pandemic. There is studies on counting how bad it is, but very little on actually doing something about it. And given the scale of needs, that's kind of quite incredible. So a big problem going forward is how to communicate effectively to look after the public and the distress that's there. And an aspect of writing the paper I also wanted to bring up as an issue was this: what does it mean to work together? And I was very grateful, and I guess that's how we've become in contact, to hear that from the Norfolk Council of Bioethics, it was noted that it had been seen as useful to include as many people's lived experience as we did as equal co-authors from the very first day, even writing under extreme speed and stress. We met every day, worked around the clock at the beginning and tried to adapt processes. And I feel very fortunate to have worked with an amazing group of colleagues, thinking about public involvement of research, even at speed, from the earlier stages. I think we need to think more globally and join up between organizations and countries, and that's something for mental health that's going to be important. It's a very global issue. And the group that I happen to work with is most at the moment our frontline staff, who you all know from the news, in the UK at least, already suffering about 40% PTSD. To have PTSD, I'm very happy to describe it in later, but this is an incredible thing. Not only does it affect the individual, but it affects your ability to work. So I think we're perhaps communicating and underestimating how much mental health is affecting the health, not only of the individual, but of people who need to care for people, and therefore, in a sort of, as it were, a circle, our ability to look after the pandemic itself. Our existent treatments are not enough. They weren't enough before the pandemic. They're not enough now. They don't meet the scale of need. They've been designed for a day where people sat in therapy offices and met once a week in Hampstead. They're not actually designed for a global pandemic and seeing equal need across the world. And therefore, I think there needs to be some quite deep questions about ethics in the mental health field, about what we mean by psychological treatment intervention, and can we design interventions from the get-go designed for global reach and scale and mental health. And working with frontline staff, and I'd be keen for the students and other medical staff for you here, it's something about fitting things into the lives of people doing jobs and when they need support and mental health support, not taking people out of their work contexts. And perhaps in all the awfulness that the pandemic is seeing. If we go back 200 years, Linnaeus got his first grant in the Spanish flu in 17 something or other here in Uppsala, and set off to Lapland and classified plants, and it brought about a revolution. Could we do something useful from this awful time now and start rethinking how we treat mental health? Can we use ethics in the middle and try and actually reach more people? I don't know, but I think it's time to think. And I would love support and discussion with colleagues with your expertise in thinking how we can deal with something which feels like the hidden pandemic behind the pandemic right now. So thank you very, very much for your attention. And I'll stop here in the interests of the other speakers. Thank you.
Thank you so much, Emily. I found that quite hypnotic, actually, which is why I thought perhaps you had 2 or 3 slides that you were coming to. I was still just engrossed in your narrative, so thank you so much.
Sorry, I just get the prize for Zoom gas, sorry.
It seems unfair to give 15 minutes to such an important thing, and I hope at a future event we can revisit in much more detail some of the things that you've kind of highlighted for us. It's certainly present in all of our everyday work at the moment, so thank you so much for being here from Sweden. Thank you. So I'm going to hand over now to Kath Mannix, who is a consultant in palliative care at Newcastle upon Tyne Hospital, and she wrote a book which surprised her apparently when it became a bestseller, but it sounds absolutely brilliant, and we're going to add it to my reading list. But thinking about the way people live while they're dying, entitled The End in Mind. So thank you so much for being here with us, Kath.
Thank you so much, and thank you for inviting me. And for full disclosure, I'm retired from palliative medicine. I worked in palliative care for just a bit over 30 years and took early retirement to work for better public understanding of dying about 3 years ago. And goodness, how we have come to understand how important public understanding can be. I'm also a qualified, and was until I retired, practicing cognitive behaviour therapist. So during the first COVID wave locally, I was one of the consultants who was given back their GMC number and was able to go back to work. And what my organisation asked me to do was not be patient facing, but to work with them on staff support and in particular communication skills training for those really difficult conversations that we've been hearing about in terms of remote bad news and enabling families to say goodbye through screens, which has been really, really difficult for people. So
that's the perspective I shall be coming from. And being asked to speak today made me have to stop and really think for the first time properly about what dying well is. I think I had a gut feeling of it rather than a set of principles or definitions. And so these aren't validated by any external body, but what I think we will mean by dying well is that somebody is relatively well prepared, that the symptoms of whatever illness they're dying from are well managed, and they're best managed if they've been anticipated, that the person is as accompanied as they wish to be. There's a fond picture of the perfect deathbed being surrounded by loved ones. That's the worst imaginable thing for some people, and some people have no loved ones to be with. But to be as accompanied as one wishes, I think, is dying well for them. And that during that time, their autonomy is respected, that they retain personhood, and their wishes are respected as far as that's possible.
I'm so sorry to come in, but we think we've lost a bit of your volume. I didn't want to make the same mistake as I did with Emily and not say anything.
Okay, let me just fiddle with my settings. Is that any better?
For those on camera, do you want to nod if you can hear better now?
I think you might have knocked something, like maybe where your headphones are going in.
I think what I'm going to do is remove, is that better? I'm removing my headphones.
Yeah.
Fantastic, thank you. That's
Hooray. So thinking about dying well, thinking about speaking well so people can hear you, thinking about being able to respect what people would like. So let's have a think about how we were doing before COVID came to knock on our doors, and then what the impact of COVID has been. So before COVID, we were trying to advance the cause of a process that we're calling advanced care planning, which is about honest conversations about life expectancy and likely trajectory of life-threatening and long-term conditions, so that people have realistic expectations and can plan accordingly. And that when the plans are made, they're centered around what's important to those people, but then they're joined up across health and social care sectors, as well as joined up with their families and their supporters, and that the records are joined up as well. To do that, we need better public understanding of dying, and you don't need me to tell you that that is not a thing. But perhaps you do need me to tell you that clinician familiarity with dying is also not the norm. That nurses are very familiar with dying, but only if they work in clinical arenas where dying is common. Geriatricians, primary care doctors, and palliative physicians are relatively likely to be at bedsides during the dying process, but most doctors do not engage in in-depth clinical care at the very end of patients' lives. So now we have a pandemic, and advanced care planning is only taken up pre-COVID by about 5% of the population anyway, and it's clearly never been thought about by people who were well before they contracted the virus. So we're now engaged in front of house triage, and people have talked already about the rules for resource allocation. I'm going to come back onto that. At the same time, we've got a media bandwagon, which is almost mischievously misperceiving advanced care planning as rationing or being left to die. So a very careful clinical decision by a GP that a person with dementia who is easily confused and frightened would be better to remain in the care of people they know, in a room that they recognize, even the people they know are wearing PPE now than to be taken to a completely unrecognizable environment and be terrified by dealing with people whose voices they don't recognize in a room that they don't recognize. And the Daily Mail would call that careful decision being left to die. And this is a sudden and unexpected illness. It's unexpected by well people, but it was new to all of us as well as it was new to our patients. What about that desire to be managing symptoms well and managing them? Well, before COVID, what we would be trying to do would be to plan what symptom management would look like, put the prescriptions in place, make the drugs available, and there would be a plan for escalation of care. And that's not the same as escalation of treatment, that there may be ceilings of treatment and intervention, but end-of-life management is never less care. So there would be plans for escalation of care, and that might be along familiar and predictable trajectories, or it might be people who present in an emergency and they very rapidly are recognized to be sick enough to die, yet possible to save. And one of the things I'm working on is encouraging people to recognize that that requires parallel care, that the end-of-life care and conversations need to be put in place today in case tomorrow is too late, at the same time as and alongside attempts to save a life. Or sometimes people present having been previously well, sudden emergency, and they die during treatment. But now suddenly the capacity of the system is threatened. So there's reduced system capacity, both in primary care and in hospital. And I think the pressures on primary care have been horribly overlooked in favour of looking at pressures in hospitals. And so now people who are dying as anticipated from their long-term conditions are not able to access the same amount of community support or hospital support that previously they would have been able to access. And non-COVID emergencies are being held back and displaced. And there's been a national scandal about it as Panorama started reporting that cancer diagnoses and treatments were being delayed, and that there will be excess deaths from cancer because of delays during the first wave of COVID treatment. We then have this group of COVID patients who are highly symptomatic at presentation. If you're so sick that you need to go to hospital, you feel awful. You are very, very breathless. You feel like you've been hit all over by hammers. You need your symptoms to be attended to, regardless of whether you're going to survive or die. But the overwhelming numbers and missed perceptions of what palliative care is, believing it to be end-of-life care rather than active symptom management, means there have been missed opportunities for symptom management for people brought into hospital with COVID. And they are all being looked after by people who are not used to delivering end-of-life care. We have repurposed the wards that we were not going to use during COVID, neurosurgery wards, dermatology wards, places where end-of-life care from somebody dying of breathlessness is vanishingly rare, and yet trying to deliver end-of-life care for those people. What about accompaniment? And Dr. Boo's already talked really eloquently about this. Before COVID, one of the things we would discuss with people would be their preferred place of care during the end of their life and who their companions would be. And it would be really important that the companions also understood what was going to happen, so you don't suddenly have somebody going off plan when one of the relatives or friends panics. An important thing to recognise is that in hospital and at home, staff role includes not just care for the person who is dying, but care for their companions too. And we know that if they get good care, good explanations during the dying phase, then the person they're looking after is not surrounded by anxious people, so they are calmer. And also understanding the trajectory, understanding what to expect next, leads people to be less fearful, to be more engaged, to be less traumatized, and therefore to have a better bereavement. So there's an important role of visitors in the care of their beloved dying person in terms of elevation of mood, spiritual companionship and care, being able to say farewell, and really importantly for all of us as humans, we understand things as stories, and understanding the story of the events that led to somebody dying is something we have done since time immemorial. What time they last sat up, what the last drink was that they had, what they last said to me, what they last said in the world. And these are the stories that we weave and tell and console ourselves with in bereavement. And of course, during COVID, we had limited visiting, both at home and in hospitals or other places of shared residence for the protection of other residents. And that has led to loneliness. It's led to people being unable to weave that story. And it's meant that staff have carried the additional burden of whispering those secrets, being present in a way that's much more intimate than previously at bedsides, to be able to phone an 80-year-old spouse who doesn't have the mobility to be with her husband in hospital and convey his last words of love to her and hers to him. The thing that I found when I was working in staff support was that there were many, many distresses for staff, but the one that everybody mentioned was their distress at patient loneliness and their inability to have the people that they loved beside them. So when we think about respecting people's wishes, advanced care planning includes discussion of preferences, including people's preferences about some of the more aggressive forms of intervention that we can offer, not so that they can demand them, although public understanding on that is very unclear, but so that they can, if they wish, make an informed refusal, and if they wish, they can make an uninformed refusal, and it is their right so to do. That relies on high quality conversations, and I think that was improving, but had a way to go as COVID hit us. We weren't really doing great about talking about dying by calling it dying before COVID. And now suddenly we are speaking down the phone. We can't see the person. It's a 111 call. It's a paramedic who has a list of calls to make, trying to make decisions in somebody's home. Options that are available are limited. And so we're doing advanced care planning by triage, everybody trying to use ethics frameworks, but there were competing ethics frameworks to think about in emergency departments, at the same time as any attempts at public discussion were utterly jeopardized by dreadful media coverage. So it's very hard to respect people's wishes if they are already defending themselves against a belief that their wishes will not be respected, because they come out fighting instead of coming out to discuss and to be understood and to be helped to make decisions. So when we think about the isolation of the dying, which was the national response to limit transmission of virus, I do want to think about this under Bisham and Childress's 4 principles, because it made me have to stop and consider what were we doing and for whom. So people's autonomy was curbed to some extent by resource availability. And so the justice of those compromises needed to be absolutely available for challenge. It needed to be transparent. It needed to be explained and understood, even if it wasn't going to be accepted by the individuals. Isolation was imposed with a good in mind, but whose good? We protected staff, we protected visitors, and we harmed the patients who were isolated, but we probably also harmed their relatives who will feel the impact in their bereavement. So this is a really interesting double effect of making a decision which we hope will intend a good, but recognizing that there is an inherent harm in that decision at the same time. The justice principle, I think, has been the most difficult of all and has been the core principle because of resource allocation. We need the public to understand about equity and what we do when there's limited access, particularly to higher level care. Because we're a high income country, we're not used to that at all. And we have much to learn from low and middle income countries about allocation of resources when they're limited. Really important that triage happened front of house in terms of at what level somebody would no longer be well enough to be able to tolerate the next escalation of treatment, so that staff at the bedsides were not also trying to allocate resources to individuals. So I want to think a little bit about public understanding about resource allocation. And I found this diagram a few weeks ago. And I think it's a really interesting diagram because of the mistake in it. So I'm just going to let you look at it while you think what the mistake in it is, because this is a high income country mistake. And the mistake is that the reallocation of the resources is not a reallocation, it's an addition of resources. This is not a resource limited diagram. This is the resource limited diagram, where now the 3 boxes are distributed amongst these 3 spectators who are trying to watch a football match over a high wall. But in fact, the wall might be so high still that 1, 2, or even all of them are unable to achieve their objective. And that's not a way that we're used to thinking about what is my right as a patient of the National Health Service in this country. And we haven't been helped by media reporting over this time. So it's been a learning curve for us all. What we are realizing is how much autonomy is threatened if good information isn't made available. And I have to say, public education during this pandemic has been woeful, or if misleading information is promoted and accepted by the public. That what is good is a societal construct, and it depends on whose good we're intending. So we know that there can be conflict between potential goods, and how do we think about the person who already is so sick that they can't survive, the person who will mourn the death of this person who can't survive, the staff who need repeatedly to have these heartbreaking conversations and be well enough to carry on caring for all of the other patients in their care. And so one of the things that's interesting here is that the intention not to harm, which often is kind of glossed over, I feel, moves up the attention order. It might be that first do no harm becomes a higher order principle for a period of time when resources are not available for everybody. So it may be that the best thing we can do is enable somebody to stay at home if they're not prepared to risk dying alone. Thereby they increase their risk of dying, but they reduce the risk that should they be dying, their beloveds won't be around them. And these are really, really difficult decisions for individuals to make when they already feel wretched. And we're seeing, we've talked about it for many years, but we're seeing it live, that justice absolutely requires transparency. We must be able to see how we're allocating constrained resources. We must be thinking about ability to benefit rather than everybody gets the same. And one of the things we've never been good at doing is discussing futility. We need to be able to recognize it, we need to be able to name it, and we need to be clear that we're not confusing that with judgments about an individual's value or their life. And I'm sure Tom's going to pick this up and talk about it in much more detail. So I wanted to speak briefly and have more time for discussion, and to thank everybody who's spoken so far, because I've learned absolutely loads today.
Thank you so much. That was beautifully and very sensitively evoked, and for those of us that are working clinically during the pandemic, speaks to so much of our experience. I think of what we've had to manage both in and out of hospital. I can see some of our colleagues writing into the chat about some of the experiences that they're having, both regarding end of life care and mental health. So thank you. It's a shame not to have a chance to draw breath, but I hope you can hold what's come to your heart and your mind through that presentation, and we'll move on to hear our final speaker, and then there'll be chance to share within our breakout room. So a very warm welcome, Tom. This is Tom Shakespeare. He's a professor in disability research at the London School of Hygiene and Tropical Medicine, and I can't wait to hear what you're going to share with us, Tom. So over to you. Thank you.
Thanks very much for having me, folks. And I regret I haven't got any slides, but you just have me for 15 minutes. It's a great pleasure to follow on Dr. Holmes. So fascinating. And we're hearing in the chat box about so many people working in mental health care and the healthcare burden of this pandemic. My team are doing research in Zimbabwe, in Nigeria, Sierra Leone, and Malawi about the impact of the pandemic on people with psychosis. So it'd be good to talk to her later. And of course, disabled people, as Dr. Mannix's wonderful talk briefly highlighted, but disabled people have particular fears, and I think they're not managed well by the debate in the disabled community. And I think we do need to have really much better communication between palliative care doctors, bioethicists, and disabled people, better to understand the issues that we're now facing. And I think disabled people have got it wrong. For example, there's been a discourse that disabled people are not vulnerable. And I think there is an issue. Disabled people are at risk at any rate in this pandemic in a way that they're not generally, and we need to address that face on. I think disabled people have had a fear of do not attempt resuscitation notices. And I think a lot of this has come out of, some of it has come out of inappropriate usage of DNAR by doctors, that's true. But much of it has come out of a fundamental misapprehension by disabled activists of DNAR. And I think we still need to have a better debate about that. Brian and I and others have been talking about this for 20 years, but it's still a communication issue. And I think the third issue that we need to address in terms of end of life is about triage and about the fact that there are a limited, as Dr. Mannix has said so eloquently, a limited supply of intensive care nursing and medicine, limited supply of ventilators, and they are not used, I think, in the NHS on the basis of people's worth or value, but on the basis of who can benefit. And I think that communication has to be made again and again and again, and has been distorted by some of the inappropriate messaging within the disability community as much as anything else. So I'm going to give you some empirical information because I'm fundamentally a social scientist. So I'm going to report on qualitative research that we've done in England and Scotland over the last 6 months with 69 disabled people and 28 disability organizations. And I'm going to present very briefly the findings. And I want to talk really, I want you to understand the backdrop, and that is that disabled people in general, on our average, and we're all different, experience a triple jeopardy in this pandemic. The first jeopardy is from COVID-19. I think disabled people are much more likely to contract COVID-19 and more likely to die. Half of all disabled people are old, 45% of those 65 and over are disabled, and sadly we know about the differential impact on older people of the virus. People with comorbidities are sadly much more likely to have a bad outcome from COVID-19 infection, and some, not all, some disabled people have comorbidities, and many disabled people have a narrower margin of health, as we argued in the World Report on Disability. Some disabled people live in care situations, either in care homes or receiving home care or personal assistant care, all of which puts them, I'm sad to say, at high risk of COVID-19 infection. So there are multiple reasons. The first jeopardy is COVID-19 itself. The second jeopardy is that disabled people are more likely to need health and social care services, health and rehabilitation services. We need physio, we need, if we're children, often speech and language. We need assistive technology, particularly as we become old. I can't tell you how long I've been waiting for a new wheelchair. We lose function if we don't use it. And one of the things we found in the interviews, I've been doing a lot of work with people with dementia, is that folk with early onset or who are new diagnosed with dementia but don't have the more advanced level of dementia have participated in the community up to now don't, and a lot have lost that capability. And that's just some small vignette of the complex ways in which being excluded, being doubly excluded, has really affected disabled people. So we've talked to disabled people in lots of all sorts, physical, sensory, mental health, intellectual disability, autism, and so forth. CEO of a large disability organization, 5,000 members, I quote, "Without being dramatic, it's been catastrophic. It has taken existing inequalities that disabled people experience, and it has magnified them and exaggerated them." And I want to talk in 4 ways. The first of all is disabling disruptions. So lots of social practices and routines were disrupted negatively, including, I mean, I've talked about rehabilitation, all of those services. You can't deliver many of these by Zoom. A friend who's a physio working with children with cerebral palsy says, you know, I stand at the bottom of their drive and I shout instructions to them to try and avoid contractures and do the stretches. It doesn't work. A lot of this doesn't work unless you can be hands-on or face-to-face. Some of it works, and we hear that some mental health interventions have worked, but a lot of it is hands-on, and if you can't do that, it doesn't work. In addition to this sort of disruption, there's this disruption caused by failure to think about disabled people. Disabled people have been an afterthought. One of the examples would be children in education. So where online education was delivered to non-disabled children, it took time for it to be delivered, adapted for disabled children, children with special educational needs and disabilities. And this is what we've heard. It has happened, but it was late. Another very symbolic example, the Prime Minister and others do these 5 o'clock briefings, never with a sign language interpreter. Now, you know, it's not that deaf people are that great a number, but it's also that it's not that much of a difficulty. Other countries do it. Why can't number 10 do it? It's sending a terrible message that disabled people are not important. A lot of folk who are stuck inside for weeks at a time, struggling with shielding, struggling with mental health issues, anxious. This woman, Lily, who's saying, I can't go out for the fear of dying. And then when I do go out, when I do go out, I'm running. I'm moving away from other people quickly. And remembering that social connection is so important for many people, including many disabled people who risk losing it. And what we've found out in terms of people with intellectual disabilities, many of us who are non-disabled have a social network. We speak to people on the phone. We have a little, you know, family Zoom chat, or whatever it is. But lots of people with intellectual disability, their social world is artificial. It's created by services. It's created by the day center they go to, by the art club they go to, by their friends, are all through services. And then you take away the services because you can't meet. And I'm not blaming anybody here. I'm just saying it's a fact of fear of the virus. And people are sitting at home all day watching television because that's all they have. Nobody else, nothing. Sometimes their family. So this afterthought, and we're talking about 15–20% of the population, this afterthought. And, you know, we know that nobody was well prepared, but by now, in the second wave, we should be doing this better. We know what happened in care homes, and what we're hearing from our friends working in social care and from their clients is that whereas there is PPE in hospitals, glad to say that, there is not PPE when you're in domiciliary care. You know, that our organizations in the social care organizations have had to ferret and fossick for PPE to make it available too. And of course, if you are a social care recipient, you can't self-isolate. You can't do things for yourself. You need somebody to come into your home, possibly somebody different every day, and to do things physically with you. And that puts you at risk, puts them at risk. Rates are higher in domiciliary care workers as well as residential care workers. So there's a problem. And further to that, the Coronavirus Act explicitly suspended the Care Act, which meant that local authorities did not need to meet the needs of disabled people in the same way. Now, it's true that not all, or not so many local authorities have taken these reversions and not met their requirements under the Care Act. But a lot of them have failed disabled people. Social care assessments put on hold for 4 months. This gentleman, I've been stuck upstairs for 14 weeks because my stair lift is broken and the local authority have been arguing with me about replacing the lift. They want me to live downstairs. I've been staying upstairs for 14 weeks. This gentleman with autism, Michael, an intellectual disability, lived in his own home with support, now moved back to his family. And he's not used to being in a family. The family are not used to being with him. He's got some complex behaviors. He's very distressed. He's having seizures and it's not really working for them. And this disappearance of social care has left people rely on their families. So it's almost as if we turn the clock back 20 years. A lot of people, so for example, I talked to a couple with mental health needs. Their sons, adult sons, had been furloughed, had moved back into the house. This couple had said to social services they didn't need help. And remember, a lot of people are frightened of others coming into their home. And so their needs are being met by their sons. Now, what happens after this terrible pandemic? The sons will go back to work. The sons will leave home. The parents will have to renegotiate social care contracts, which have kind of lapsed. Yeah, a lot of people feel let down by social care and worried about the future of social care. Let me fast forward a bit. The third sector have done really effectively in this. Just want to give you an example. Glasgow Disability Alliance had a budget for meetings, getting people together. And immediately on COVID, they spent the whole of that money in buying notebook computers, iPads and similar, to give to their clients, 500 clients, so their clients could access the internet. Because if you can't access the internet, and disabled people are older and far less likely to access the internet, you're really stuck. I mean, this is a wonderful opportunity now to talk to you. I got an online care food delivery earlier today, and I'm gonna, speak to somebody at 7 o'clock. But if you don't have internet, and disabled people often don't, you're really, really excluded. But internet isn't everything. Many people want touch, want presence, want connection, and so there's an isolation which comes of being in your home, of shielding, which is a real problem for people. And some disabled people have said to us, what we fear is after the pandemic, it's great that we can access everything and we can, there are no access barriers. We're all on the same plane. Why on earth could you not have done this before? Why did it take a pandemic before you allowed us to participate online? But the downside of this wonderful participation online is that after the pandemic, what's going to happen? Are we going to say, oh, we don't need to bother about access because people can do it online? They don't have to come to our meetings, they can do it online. So some disabled people are quite worried. As one disabled person said to us, you can't play pool on Zoom. And it epitomizes what they got from day centers, really. Final message, I mean, this is common to everybody. It's about messaging and leadership, frustration. Some people got shielding letters, a minority of our sample, but many more people thought they should be shielding for different reasons. And the messaging are like, August, oh, you don't need to bother to shield anymore. Some people carried on shielding. And here we had a big difference between England and Scotland. In Scotland, they trusted Nicola Sturgeon. In England, they did not trust the Prime Minister. And that's not a party political point. It was made spontaneously by loads and loads of people. And if you're not on the list, if you're not getting a shielding letter, you do not have priority over food deliveries, even though you've been relying on food deliveries forever. And the only reason I got a food delivery this morning is because I wrote a really stroppy letter, because I'm a very educated middle-class person. And I said, look, I can't carry much shopping. I need to be on your special list. And of course, they put me on a special list. But how many people would do that? How many people would write to the customer services and do it? A lot of people I've seen are saying, I can't get a delivery. So as I said, triple jeopardy, COVID, postponement of regular health and social care services you might get, and thirdly, social exclusion. I mean, just have a think. How can blind people socially distance? They can't. How can people with intellectual disabilities? The whole area of care is touch, is feel, is being with each other. And so there's a great loss. And I'm not saying this is all the fault of anybody. It is a consequence of the pandemic, but also of our failures properly to react to it. And I'll leave it at there. I've talked too much. We haven't got much time. I'm very happy to answer questions. Thank you.
So much, Tom. That was compelling. My pen couldn't keep up with my brain as you were speaking.
Well, it's hot off the press. We're going to submit this paper this afternoon, and it'll be on open access, and I can, through Brian, tell you what the link is.
So the only thing that I would probably celebrate in this pandemic is the way that we have been able to accelerate our inclusion work in Manchester because of this chasm of inequality that we've revealed as a society. So for those of us that have campaigned for equity around disability and BAME colleagues and people in our city over many years, there has been some ground to gain. So Brian and I have been having a debate about whether we go to breakouts or whether we ask, give you a chance for 5 minutes to ask questions. And I just think, given the nature of the conversations we've just heard, I wonder if we have time for one question to each speaker. And I wonder if I guess we'll go first come, first serve in the absence of a more equitable way of doing things. But if you have a question for any speaker, please shout now, and then I'll offer up for whoever doesn't get the first question, and then I'm going to hand to Carolyn to end the conference today. So would anybody like to ask a question to any of our three speakers? So I think some of our junior doctor colleagues were making some good points. So I don't know, is Harleen still there? And if you are, would you mind sharing your observations based on Emily's presentation?
Hello. So I'm Holly and I'm a junior doctor. I'm currently working in an intensive care unit and I've been working in one since last July. And something that we noticed over July was that we started seeing lots of patients presenting with mental health related issues. So they might have been alcohol related, issues leading to pancreatitis or seizures or acute withdrawal, or a lot of deliberate self-poisoning and a number of attempted suicide. And it was really challenging, and with mental health services being stretched as they are, liaison services weren't able to provide the support that we needed, and our own ICU staff were struggling to support patients with mental health problems when they didn't feel like they'd had adequate training, but they were still recovering from the psychological trauma of the first wave themselves. And then, having seen that, we've now gone into the second and third wave.
I can't hear actually at the moment.
We've just lost your volume, I'm afraid, Harleen. Emily, do you want to come in based on what you'd heard already? Is that okay?
Yeah, and whilst Harleen's fixing her volume, thank you for your comment, Harleen. I'm just looking at it in the chat as well. So if I understand correctly, not only have I seen you been working everything they were doing in the pandemic, but then you've got this extra influx of patients in between, and you've called it in the chat as like the other pandemic of mental health. And when services are forced, then it's spilling out elsewhere. I guess that underscores exactly what I was trying to say, which you wrote very calmly last April, and now feeling a sense of increasing alarm that we're utterly underestimating the mental health consequences. And from an ethics point of view, I want to go back to John's talk at the beginning, because you talked about an unreasonable level of risk. And whenever we talk about this, we talk about things like protective equipment or how people are kept physically safe. How do we apply this concept perhaps to staff's mental health and well-being of our patients when we know the science already tells us repeated exposure to trauma, it's a dose-wide response? From what Tom said, loneliness, social isolation, from what Catherine said, the relatives, and physical mental health has an enormous physical impact as well. It's all reciprocal. So I really hope we can broaden out this idea about unreasonable risk to staff and patients as including the mental health as well as the physical consequences of this pandemic.
Thank you so much. And then Miranda's written in the chat based on Kat's presentation about how influential you've been. And I don't know whether it's worth just reflecting on, for those of us that do palliative care, talking about death is part of what we do, isn't it? But I was really struck by your comments that this is still so important, and clearly you're very influential for medical students. I don't know if Miranda wants to make any comments, whether you want to sort of speak to that, Kath. Are you still with us, Miranda?
Yes, I'm still here. Yeah, it was just to say really what I said in the comments, but through our teaching, quite often when we talk about palliative care, we are signposted to some of the videos that Dr. Mannix has made as well with the BBC, and then also to her book, which has also been so important for us to read. And I think for both a professional level, but also on a personal level, and I think almost gave me the tools to kind of look back retrospectively on loss and death and actually understand it retrospectively in a way that I didn't at the time as well. But also even things as small as in my presentation when I said, as well as when some of the patients died, I'd initially written something like passed away or a different word, and actually kind of with Dr. Mannix in my mind, I was like, no, you use the word, they died. And so things as small as that, as changing my language and thinking about how we use them, has been absolutely huge. So it was really great to get to hear you speaking today. With obviously your book was written before the pandemic, but to now hear your offerings in the context of the pandemic was really powerful as well. So thank you.
Thanks, Miranda. And I think it's probably worth thinking a little bit about how public understanding of dying has become lost. And because it has become lost, when we're training healthcare professionals, we have to replace it. And yet currently, largely, we don't. We take people from a society that is death unaware at its least negative and death averse at its most negative. And then we teach them as nurses and physios and speech and language therapists and doctors and all the rest of it to save lives. And we don't actually talk about the fact that every patient you look after is mortal, and there will be a dying phase in every life, and we are still accountable as clinicians. When life can no longer be saved, we can still save the death, and we need that to be a learning outcome of our health schools. I'll get off my soapbox now.
And I'll get onto mine, because I thought it was very interesting when the death figures were released in the COVID-19 pandemic at the start. And what was the message when we kept on hearing about deaths? They had underlying conditions. In other words, it's okay, they died, you won't. And I think it's been a big effort of doctors to show people, and nurses, to show people that actually young people are also vulnerable. And, you know, but also to say, you know, the fact that these people had underlying conditions does not make them less valuable as human beings. They were loved, they contributed, and it's really shocking to say, oh, it's okay, they had underlying conditions, they're not like you.
Thank you, Tom. I think in the interest of time, you've spared yourself a question, but I am noting the reflections on the power of touch in the chat box. And as a GP, I've grieved for not being able to touch my patients. And I've also realised I can't actually do dermatology without touching people. It's the one time that I still need to bring people in, even apart from examining abdomens. So thank you so much. Thanks to all three of you. It's been a privilege to chair this part of the conference, which has generally been an amazing day, but thank you for letting me steer this last hour. I'm terrible at timekeeping. I was very well known for it. So I'm going to hand over with only 3 minutes over time. And thanks to you all again.
Hello, everybody.
Eyes there, great.
I haven't disappeared. So thank you, everybody who's contributed and organised today's conference. A bit like Ruth, I've been struggling to keep up with my typing with all the various contributions. It's almost as if every minute has been valuable. Pretty much literally. So my attempt to summarize is going to be a bit of a challenge, but there's a few things I think I would like to reflect on. I think the first thing that I should say, and in case you don't know, I'm the secretary of the IME and a trustee too, which is partly why I've been asked to sort of summarise things in Wing May's absence, who is our chair. I think I should probably say a few things about why we're here and how we're here and the IME. So the Institute of Medical Ethics has been doing some soul searching, I would say, over the last 10 months since the pandemic really hit the UK hard. And one of our observations, really, one of our reflections is how hard it is to be resilient as an organisation and as individuals in the middle of a pandemic or a national or global crisis like this. And in a way, we were asked earlier on to reflect on our hopes and expectations for the conference, and I quickly piped up that my greatest hope is that we would be here and that we would be addressing ethical issues in relation to COVID, and here we are. We've made it to this point. Brian mentioned at the beginning that we had intended to do our annual conference back last summer, but that was kiboshed by COVID, and yet we have managed to get ourselves back on our feet and been able to focus on the ethical and legal issues that pertain to this particular crisis, and I'm delighted about that. And Brian also mentioned at the beginning that the IME is not very good at reading tea leaves, and I suspect that's true, but we are very good at enabling ethical discourse, and I think, you know, thanks to the contributions of everybody, we've achieved that today. So I think the other thing that's worth saying from my perspective is that, you know, what we're witnessing here is, of course, an innovation in terms of how we're delivering a conference. We've always opted for a face-to-face conference, but here we are doing something online. Of course, we're all very familiar with doing that now, I suppose, but it has its virtues doing things like this. It brings people together, not only across the UK, but elsewhere. And I'm sure that this particular innovation will be kept in some format as we move through 2021 and so on. Also, a quick shout out to those who've been contributing to the social media aspect of today. So I know that the Twitter feed's been quite active, and I think it's important that we not only have an internal conversation like this, but that other people who aren't able to attend are able to be aware of what we're doing and what we're trying to do. I think the other reflection for me on all of this is that for those of you who know me and know what I'm interested in, global health has long been my area of interest. And in a way, what the pandemic has done, in a rather brutal way, of course, is demonstrated the importance of global health, not just to others, as it were, people beyond our shores, but to everybody, including people like us living in the UK. Global health, you know, is at the heart, I think, of 21st century healthcare, or it should be. The pandemic's demonstrated precisely why that's true. And of course, the pandemic is only one aspect of global health. Perhaps a much bigger crisis that will come in the future is the climate change one. It's already having an impact, of course, and is going to have an even bigger impact going forward. And I think it's important that the IME and indeed researchers, educators, clinicians, all of us start thinking hard, as clearly people have been doing, about global health issues. So from my perspective, personally, I think that's great to see. Indeed, one of the things I was thinking about throughout this entire day was that this reminds me of global health conferences I normally attend, and but this time there are a strong focus on ethics, and it's the IME that's driving it forward, which is wonderful. I think thinking about sort of the themes that have come out from today, well, at least from what I've been able to pick up, one of the key ones is the importance of justice, the problems of inequity, and how COVID has not only shone a light on that, but has exacerbated pre-existing inequalities and inequities in many different ways. We heard about the experiences in India, for example, and just the sheer scale of harm that COVID has caused directly and indirectly as a consequence of attempts to react to COVID. That the number of people globally driven into poverty, extreme poverty, as a consequence of COVID and the reaction to it is just beyond all comprehension, really. And then, of course, inequities and inequalities are everywhere. We've heard about the impact on people who have a disability. We've heard about the impact on palliative care, on mental health. I think it was Ruth who said that, you know, that there's so much to explore in each of those areas, that, and I thought that too. And we could probably have run a conference on mental health ethics and COVID, and the same with disability and so on. In fact, in a way, all of the talks could have been the basis of a conference in and of itself. And I hope that following this conference that we will be working on all of these various issues, and perhaps be able to run mini workshops and seminars and other conferences that pick up on some of these key things. I particularly, in terms of kind of the themes as well, I think the other thing is to do with, I'm not sure whether it's sort of failure of planning, but that's what I jotted down. But in a sense, many people have been caught on the hop. Many governments have, many policymakers, many of us as educators and researchers as well, in a way that we perhaps shouldn't have been. Pandemics are not, although we may not have experienced many of them, they're not as if they're not the kinds of things that are completely unexpected. Many people have been reflecting on the 1918-1919 flu pandemic recently, of course, but as was mentioned by one of the speakers earlier on, you know, SARS wasn't that long ago, and Ebola wasn't that long ago either. I mean, pandemics are the kinds of things you'd expect to see, particularly in a globalized society. And so the fact that we've been somehow slow to react, and continue to be quite slow to react, even at this stage, is worrying. And hopefully one of the things that will come out of not just this conference, but I guess the whole pandemic, is that there will be greater focus and greater preparedness for the future, because there will be, sad to say, and a slightly depressing note, I suppose, that future pandemics, and some of them might be more devastating than this one. I think, John kind of started us off very well at the beginning of the day with a fantastic overview. I thought that, I don't know how you managed to summarize so many different things, so many key issues in one short presentation, but that really set the scene very well. I thought that the talks from Sylvia, Mike and Marion were all very interesting. And one of the things that I very much picked up from that was this focus on risk, and how perceptions of how much risk might be reasonable to take in certain situations might have changed as a consequence of COVID. I thought that it was wonderful to have presentations from students. I've been spending quite a lot of time with postgraduate students mostly, but also some undergraduate healthcare students recently. And you know, the implications and impacts on students, particularly clinical students, of COVID-19 is immense. And we owe us a debt of gratitude, I think, to the contributions of students and their I think, if you like, philosophical willingness to not complain too much. I mean, the impact on education has been just extraordinary, but rather than mope and complain and criticize, students have stood up and contributed to the NHS effort in a remarkable way. There are many ethical issues in relation to what's happened to, I think, clinical education that are worth exploring. I mean, they weren't touched upon today, but I'm delighted that we had student contributors. And then, of course, we moved on and had the sort of the global perspective from India and Singapore, and I personally found both of those talks very, very interesting indeed. The talk from Mary about what has happened in India was in many ways quite devastating. So although I'm quite familiar with the impact globally from the kind of work I do, it's just when you hear it, hear about what's happening on the ground, and the sheer scale of human suffering, it's just quite overwhelming. So I think it's critical that we had contributions globally to this conference. I think without it would have been a serious error if we hadn't done that. So I'm delighted that occurred. And the final 3 talks I've already touched upon a little bit, but picking up on the fact that current inequities and inequalities are exacerbated in the current situation. And I think one of the key things is going to take a long time for us to digest all of these impacts and to try and rectify some of the harm that's been caused. The PTSD amongst healthcare professionals was mentioned, for example. I mean, again, the scale of harm there is immense, and the amount of work that's going to be needed to try and rectify that and support those healthcare professionals is significant. So I've waffled on for 15 minutes in an attempt to try and summarize things and to thank everybody. So lastly, I'd just like to thank the organisers. So I know Brian and Phil may want to provide thanks as well, but I'll just thank them for all the efforts they've put into making this conference happen. It's been incredible, one of the best IME conferences I think I've ever attended, as it were. And I'd just like to make sure that Brian and Phil get the opportunity to thank those who are also involved in organising. So thank you.
Okay, well, I'd certainly like to thank Ruth and Pirishanti and Emma and Sylvia, who were on the organising committee for the conference and who provided considerable thought and ideas, both about the way in which we would devise it and who we would have coming to take part. And also to thank Lorraine for the work that she has been doing behind the scenes in ensuring the smooth running. I too would like to thank all of the speakers as well. There is just one follow-up meeting because we are obviously going to be dealing with COVID as an ethical issue for a while. And Zoe Fritz has agreed to run a seminar for us on the 15th of February at 5:30. We'll make sure that we send details of that round in the email that Phil is going to send round once this event is actually available online. And he's actually got that up. And I couldn't remember Kat's surname, so I'm just so glad that Phil has highlighted this so that you can read that she is Kat Cox. The two of them will be leading a discussion. And we think this may well be a good way forward for IME of having a number of seminars, whether 5:30 is the right time or 7 o'clock is the right time. We will no doubt find out by trial and error, and there may be, maybe lunchtime's better. We shall find out. But thank you all very much indeed, and thank you to those who have contributed. The last thing I would like to say is that if you've got some tips for how we would do this better, please capture them now and put them in the chat, because it's really, in a sense, there are things that we can learn. I think there are things that we're all learning about using Zoom. I didn't even know it existed this time last year. So thank you all very much indeed.